And Chris, if you want to share your screen, the floor is open to you.
Can you see my screen?
Yes, I can.
Okay, perfect. Thanks, Jeff, for this. I think it's very topical. You know, speaking with the ICU folks, it's clear that we're the worst we've been the entire pandemic in the ICU right now, from a perspective of critically ill COVID patients. And I think it's at a time where, as you pointed out, the rest of society has completely forgotten that we're still in the middle of this. I wanted to start with just presenting 3 cases that we'll come back to at the end, that I think highlight some of the challenges around decision making in these patients. The first is a 41-year-old unvaccinated male with COVID ARDS. He had a progression of his oxygen requirements in hospital over a period of about 6 days prior to being intubated. When we met him, he had been intubated for just short of 7 days on maximal lung protective ventilation. His SATs were 90 on 100% FiO2, and his PF ratio was in the 60 range. So PF ratio is partial pressure of oxygen on an arterial blood gas over the FiO2 on the ventilator. He had a history of diabetes and a BMI of 41. When we met him, he had normal end organ function, had not had an arrest, and was on norepinephrine and a lot of sedation. Case number 2 is an unvaccinated 66-year-old male. He had also been on Optiflow for 7 days prior to intubation, then intubated for 7 days. His PF ratio was less than 80, but he was on his FiO2 on the vent was 80%. His creatinine was 400, though he was still diuresing, was not on pressors, and had not had an arrest. Case 3 is a 46-year-old unvaccinated male from Bathurst who was unwell for about 7 days prior to presentation to the emergency room, at which time his room air oxygen saturations were in the high 50s and low 60s. He was intubated the same day. When we got a call, he had been intubated for 5 days on maximal lung protective ventilation. On his back, his SATs were in the 80% range on 100% oxygen. And when they tried to move him, he became quite unstable. He had a mild form of muscular dystrophy, and by history was not limited by this. His BMI was 39. So why are we still talking about this? I think, you know, this is information that is from the Government of Canada website. You can see now that Omicron basically makes up nearly 100 or essentially 100% of the current variants that are infecting people. And by and large, this is now the BA2 variant of Omicron. And I think what's changed is when you look at the number of cases being infected, unvaccinated people make up 47% and fully vaccinated people make up 35%. So clearly these new variants are not as protective about contracting the virus as it was early in the pandemic. Thankfully, you know, the being fully vaccinated, especially vaccinated with an additional dose, is still protective against death and by and large hospitalization. But you know, we are clearly still in the middle of this pandemic. And when you look at the patients admitted to hospital, you see, you know, over the last couple of months here, a huge increase in the number of COVID patients admitted to hospital, albeit not necessarily in the ICU. And then down here, you can see that, you know, as we've gotten towards the middle of April, that this again is starting to rise. And I think it sounds like this is worse in our province than what the national data suggests. And I don't know if that is because we were relatively protected early in the pandemic, but something is driving a pretty significant increase in the number of patients in the ICU we've seen here. So the next question is, what is ARDS? This is a picture of an alveolus, and on the left side of the screen is a normal alveolus. You can see an intact basement membrane, intact endothelial lining of a capillary, a normal looking alveolus. And ARDS really comes from an acute diffuse inflammatory lung injury, and it leads to breakdown of the basement membrane, a breakdown of the capillary bed and endothelial cells, you get microvascular thrombosis, and you get, you know, non-hydrostatic pulmonary edema. You get fluid flooding into the alveoli, which result in hypoxemia, poor lung compliance, and a significant systemic inflammatory response syndrome. Now, over time, hopefully that you start to get healing, you get reconstitution of the basement membrane and endothelial cell healing, and some of this fluid starts to be resorbed, and you start to see improvement in oxygenation. What we want to avoid is this rightward panel, which is a progression to pulmonary fibrosis. You get, you know, obliteration of the capillary bed, fibrosis and thickening of the space between the alveolus and the capillary, and you have stiff lungs that you're not able to ventilate. And preventing this progression is really the end goal of ECMO, is to minimize ventilator lung injury and minimize progression to this fibrotic state, which is associated with difficulty getting off the ventilator and excess mortality. So ARDS management goals are to treat the underlying cause. In this case, do your best to treat a viral illness. And the principal goal is to prevent ventilator-induced lung injury with lung protective ventilation, which we'll talk about in a minute, and really provide an opportunity for lung recovery and to prevent that progression to pulmonary fibrosis. So what is lung protective ventilation? Well, we're trying to prevent cyclical collapse and re-expansion of underventilated alveolus, and prevent overexpansion and barotrauma of alveoli that are prone to that. And so we want to keep our ventilation in this middle range where we're avoiding either end of the spectrum. And that's relatively easy. In a normal lung, you need adequate PEEP to keep the lung open and some driving pressure to maintain a tidal volume that is within this safe zone. But an ARDS lung is a very different animal. You have areas that are overventilated relative to their perfusion. You have areas that have some degree of VQ matching. Then you have areas that have diffusion impairment, and then areas that are really shunt physiology and not recruitable. So how do you ventilate a lung that looks like this? And where is most of the injury occurring? So if you look at this yellow zone of lung, if you don't have adequate PEEP, it is going to cycle across this lower inflection plane with cyclical atelectasis and re-expansion, which is injurious. And then this more healthy lung that is very prone to barotrauma and overinflation with inspiration. And so the impact of PEEP and tidal volume can have a great impact on the degree of lung injury. So if you have low PEEP, then all of your lung is down here, and a substantial portion of it is subject to the damage from cyclical atelectasis. And if you have large tidal volumes, you force lung up across this upper inflection point, and a lot of lung that is subject to barotrauma. So that is the rationale for lung protective ventilation, which is high PEEP. So you try and keep this yellow zone of lung recruited so that it does not collapse with expiration. And then you have low tidal volume to try and protect the gray and red zones of lung from barotrauma. And so the rationale for ECMO is, if in order to achieve this lung protective ventilation, you're not able to adequately oxygenate and ventilate the patient, and that then becomes a threat to life, ECMO really provides you an opportunity to achieve that lung protective ventilation. It on its own doesn't cure any disease. It just allows you to safely ventilate the patient and hope for eventual native lung recovery. So you have the withdrawal of blood from the venous system. It's pumped through an oxygenator, which gives you oxygen supply and CO2 removal, and then it is pumped back in again to the venous system. So this is still completely reliant on the native heart function to circulate the blood, but you're oxygenating the blood before it hits your diseased lungs. So this is a 2-lumen strategy, so an IVC drainage cannula and a SVC, or right internal jugular vein return cannula. And really, this is a bit of a busy slide, but the things that VV-ECMO accomplishes, the principal thing it accomplishes is it minimizes ventilator lung injury, this volutrauma, barotrauma that is associated with mechanical ventilation. It also decreases hypoxemia, perhaps improves RV function by correcting acidosis and hypoxemia. But I think the principal way that we improve survival in these patients is decreasing this ventilator-induced lung injury. And the goal of all that is to prevent progression to pulmonary fibrosis. So when should we consider cannulating a patient for VV-ECMO? This is a treatment algorithm from the ELSO guidance document for ECMO and COVID-19 patients. And, principle is, again, treat the underlying cause of the ARDS, lung protective ventilation, try and diurese if you're able. And if their gas exchange is poor, they should be trialed with prone positioning. This is a very strong recommendation. And other things to consider are paralysis, high peak pulmonary vasodilators, et cetera. And if you fail that conservative strategy, then you consider cannulating for ECMO if your gas exchange is very poor despite that. And a lot of this data and inclusion criteria comes from the EOLIA trial, which is the best randomized evidence we have for VV-ECMO and ARDS. It was published in 2018. And I'll share the results of this a little later in the presentation. But a rough guide to our indications, or who we've considered to cannulate here, are respiratory failure that is refractory to maximal ARDS ventilation. They really should have had a trial of prone ventilation. It has a dramatic impact on these patients. One of our patients, we did not prone before cannulation because they were just too unstable and too sick. But for the most part, they've all been prone and paralyzed. And then they have a PF ratio less than 50 for 3 hours or less than 80 for 6 hours, or are acidotic from hypercarbia, though this has been a less common indication for us to consider. And then contraindications are patients that are greater than that 60 to 65 range. A big one is how long they've been exposed to mechanical ventilation for, because if they've already been ventilated for 7, 10, 14 days, you've missed your window to prevent that ventilator lung injury, and then your ability to salvage that patient is dramatically decreased. And an important question to ask too is not just how long have they been ventilated for, but how long have they been sick for? If they've been on BiPAP or Optiflow for 14 days and then mechanically ventilated for 7 days, you've missed the window on that patient. The EOLIA trial excluded people with a BMI over 45, and the national and international experience with the morbidly obese has reinforced that in this pandemic. Talking to some of the folks at Edmonton, they have turned down people in their 20s solely based on a BMI because they just don't do well. And then really any other chronic end organ failure. And we have been more selective in this pandemic as a whole, with even isolated renal failure as a contraindication. This is the EOLIA trial that we talked about that was published in 2018. So half the patients, 125-ish people in each group, one was randomized to ECMO therapy, one was randomized to standard therapy, but with the important caveat that there was the option to cross over to ECMO if they failed their conservative therapy. So you can see here the Kaplan-Meier survival curves that did not quite reach significance, but an important caveat to that is almost a third of people in the control group ended up crossing over to ECMO at a mean of 6 days after randomization. So this is a very difficult set of data to interpret because the groups are quite muddied, and a third of patients ended up getting the treatment of ECMO, even though they were in the control group. So when you look at treatment failure as a key secondary endpoint at 60 days, this was then a highly significant result with a relative risk of 0.62. Certainly a trend again towards less mortality in the ECMO group. And again, a third of patients in the control group got ECMO anyways. And then, greater number of mechanical ventilation free days, vasopressor free days, renal replacement therapy free days. So overall, consensus of this trial is that it was a strong evidence in favor of ECMO for these patients. This is the number of VV ECMO cases for COVID-19 from the Euro-ELSO network. I put this up here because almost 2 years ago to the day we gave this talk at the very beginning of the pandemic, and at that point in Europe, 300 people had been put on ECMO, and you can see now that to the beginning of March, we've now reached over 6,000 people have been supported with this therapy in Europe, and even since January, there's been another 400 people that have been put on. So this pandemic is not over. This is the number of deaths of that 6,200 people. And so the mortality is in the range of 45–50%. And talking to folks from around the country, the more recent, or certainly with Delta, the outcomes were worse than they were early in the pandemic, but survival is in the 50% range. So the next question really is, where should we cannulate? These are critically ill patients who are hypoxemic. They're often on vasopressors, and transport of these patients to an IR suite or operating room can be a challenge. They're all on full isolation, obviously, which adds an extra layer of complexity. We have cannulated all these patients in 3B South in their ICU room, but logistics are not easy with, in general, large patients in a small room with a lot of equipment, surgical equipment, and the C-arm and a fluoro screen and a fluoro stretcher. But what we found to be the safest and quickest option is to bring the fluoro stretcher up from the emergency department and do all of this in their ICU room with fluoro imaging. And our most recent patient, the where question was particularly important, as he was really too unstable to transport on his back with SATs in the 80s. And we had strong consideration for traveling to Bathurst to cannulate him. But in the end, we were able to find that the Nova Scotia air crew was able to fly him down proned. And then upon arrival here, he was flipped on his back for cannulation. The next question of where should we cannulate really has to do with cannula selection. There are dual lumen cannulas available. We use the crescent cannula. So it is a cannula within a cannula, essentially a drainage cannula and outflow cannula all built into one. You can see here, this is a crescent placed via the right IJ. So drainage from the IVC, drainage from the SVC, and then return back to the patient that is coming out of this port across the tricuspid valve. The advantages of this, either right IJ or left subclavian vein, is that you have one cannula. I think it is reasonable to suggest there's less infection to be able to stay out of the patient's groins, and it really facilitates physiotherapy when they get to that point in their stay, because you're not hindered by cannulas in the groin. But placement is a little more tricky. I think really you should have fluoro to make this a safe procedure. And the big limitation is some of these people very early in their course, when they're in the throes of profound SIRS, need very high flow rates to adequately oxygenate them. Our second last patient needed flows of nearly 7 liters a minute, and you can't get that kind of flow out of one of these cannulas. So just to get back to the cases, case 1, we chose to cannulate this patient by and large because he was young. He was intubated for kind of the upper limit of normal in terms of that risk of already missing your window to intervene. He had been intubated for 7 days, and he had not been on high levels of oxygen for that period of 6 days leading up to it, but we did have some concerns that we were a little far down his disease process to be able to salvage him. He certainly met the oxygen PF ratio indications for ECMO. His BMI was large, and the concerns we had up front, I'd say, played out in his story. We placed a 32 crescent in his right IJ. He was on VV ECMO in 3B South for the next 83 days and was in ICU here for 95 days plus an additional stay in his home hospital. He did eventually survive and was discharged home on home oxygen. This is a snapshot of his CT scan showing pulmonary fibrosis, traction bronchiectasis, and he is oxygen dependent and currently being listed for or worked up for lung transplant through the University of Toronto program. I think this is a good example of how the dangers of missing the window and why that duration of illness is such an important factor in terms of picking patients to cannulate. Case 2 was 66, so certainly on the older end of the spectrum to consider this therapy. He had been unwell for at least 7 days prior to intubation, and then an additional 7 days on high ventilatory support, which made us very leery to consider him. In addition, he had end organ failure with the rising creatinine that was over 400, and his oxygen was, though his PF ratio was less than 80, he was only 80% on the vent. So this is the type of patient, we get a lot of calls for patients like this that we declined. Case 3 is the 46-year-old male from Bathurst. He walked into the emerge with SATs in the 60% range. He had been intubated for 5 days, so was within a good window, I think, for us to intervene and help him, and was profoundly hypoxemic. He had mild muscular dystrophy, which is a concern because rehab of these patients is a challenge after a long state of critical illness. But overall, we felt we should cannulate him. The biggest logistical challenge was trying to figure out how to do this safely, whether that was to travel to Bathurst to cannulate him. And in the end, we flew him down prone. When we flipped him on his back here to cannulate him, by the time we got his cannula in, his SATs were in the 50s, and he was bradycardic. You can see the density of the bilateral infiltrates on this X-ray, and the crescent cannula coming in from his right IJ. He's currently day 11 on ECMO support and making gains. And I think we're, hopefully in the coming days ready to start a sweep trial to trial him off ECMO. To conclude, the mainstay of ARDS treatment is still lung protective ventilation, paralysis, prone positioning. I think ECMO improves survival in select patients that are refractory to this conventional therapy, provided the critical care capacity and resources are present. And I think you can imagine the tremendous amount of effort on the part of the ICU nurses, the RTs, the ICU teams, our OR nurses and staff that are very invested in what it takes to treat the patients that don't require ECMO and those that do. And I think at the end of 2 years of this, everyone is feeling really taxed, and I think everyone deserves a huge congratulations for the patients that we've been able to get through. Thank you very much, and I'd be happy to take any questions.
All right, thank you, Chris, for the provocative talk in many ways. And I'll open it for questions if you want to raise your hand, or there is one from Sharif. Go ahead, Sharif.
Thank you very much, Chris, for that. Just a question and just a thought in general. When we have some of these, approaches to trying to deal with the very sick, oftentimes it's basically a last-ditch effort. I'll just use the idea of TAVI, right? TAVI was instituted as the, well, they're not operable, so why don't we try it there? And then as over time, we've now been able to do it in less risky people. So I guess the question is, with ECMO, is there possibilities of doing it earlier, and would that prevent some of the lung injury from preventing or from actually developing, in that particular case? Is there any evidence of doing things earlier instead of having to wait till it's a last resort for these patients?
Yeah, I mean, I think it's a very provocative question, Sharif, and a pointed one. The physiology makes sense, and we don't have randomized data to support that. The cannulation criteria are by and large informed by the OLEA trial. Without a doubt, the people that do the best with this treatment are the people that get sick quickly. That come in, they're sick, they're intubated day 1, they fail day 2, they're cannulated, by day 2 or 3. Those are the people that you can turn around quickly and tend to do well. So I think you're probably right. There's no good data to support that. There's a lot of anecdotes that do, we even you know, a year and a half ago, cannulated a person who was awake pre-intubation because of bad pneumocystis lung disease and bad air leaks. So, and there are lots of case reports out there to support this, you know, an ECMO first strategy, even before intubation. I think as the therapy has gotten safer, you know, the technology of the oxygenators and circuits has gotten better. I think that risk benefit ratio is changing, though we just don't have the data to support it on a large scale yet.
Yes, I think the question is very good and provocative, but it also sort of needs the balance of, from your point of view, Chris, you highlighted a little bit of two things that are clear in my mind is that, you know, the length of support required, and obviously the end results are still, you know, while they are good, they still, I mean, these are challenges for these patients for the rest of their lives. And perhaps you improve that by intervening earlier, but there is obviously a capacity for this. You know, if I told you we have 20 patients to put on ECMO right now, we wouldn't be able to.
And
Just
I mean,
some thoughts around those things.
yeah, there's no doubt it's, I mean, you know, you think of what the ICU nurses have been doing for 2 years, which is proning BMI 45 patients. You know, the workload in full PPE, you know, the workload is just incredible. So the resources and capacity, especially during this pandemic, has really been highlighted in all the consensus documents and guidelines, that you have to have the resources to do it, because it is lengthy therapy, intensive therapy, with a, you know, a 50% chance of getting them through. So, you know, I would say that the selection criteria has been more stringent in this pandemic than it was in H1N1 and, you know, the earlier pandemics and other kind of general ARDS criteria for cannulation. In particular, BMI cutoffs and even isolated renal failure previously wasn't really considered necessarily a contraindication, but I think everyone has really trimmed down who they're choosing for that reason. Yeah.
So one more question from David Marr, and we'll close with that.
Chris, a great thank you for the presentation. It was fascinating. I was intrigued by your comment earlier about the Bathurst patient and considerations of traveling to Bathurst to implement this therapy. What were your considerations in that, given, you know, the intensity of the resources that are needed, both human and mechanical, to get this done in a periphery? That's I mean, it fascinates me.
I think what drove this was a young patient who appeared to be too unstable to transport, which then forces you to start thinking of options that are maybe less than ideal, but warranted, you know, to prevent a mortality.
I think, Chris, you just need to clarify. Maybe David thought you were going to maintain therapy there. It was really to transport the patient. It would be here
to cannulate and transport back. Thanks, Jeff. Yeah. And it, you know, if in all honesty, if Halifax aircrew was not able to fly him down prone, that would have been our only option, because he would not have survived transport on his back. So, you know, we have supplies and an ECMO circuit that are portable, but the logistics of staff transport and doing it is certainly, as you can imagine, not straightforward. And we have not done this here yet. I hope we don't have to, but we are, I think, as prepared as we can be in the event that it becomes required.
All right. With this, thank you, Chris, for the provocative talk this morning. And please, everybody, stay safe and have a good day.
Thank you.
Bye-bye.